Imagine you're in the forest and unsure of your way home, but your map is missing pieces and trails are not marked. If you're experienced in the woods, you'll likely get back home, but it's going to be uncomfortable. If you're not experienced, the situation could get very bad. Trying to practice effective infection prevention and control without good information is like trying to find your way through a forest with an incomplete map. High-quality data and analytics form the core of evidence-based practice with which all infection prevention and control professionals protect patients, staff, and the public at large. Surveillance is a primary function in IPAC programs. Documentation is part of multiple domains in IPAC Canada's core competencies, as well as being a regulatory requirement for many ICPs. IPAC programs need data for continuous quality improvement. All IPAC programs have reporting requirements to funders and the units or facilities they serve. The issue is to capture documentation and data in an efficient way that generates accurate information for the needs of IPAC programs. The Thunder Bay District Health Unit IPAC Hub serves in an educational and supportive role to long-term care and retirement homes and congregate living settings in northwestern Ontario within Thunder Bay and an area 400 kilometers to the east and north of the city. The hub has 5 main areas where data collection is needed. Ontario's IPAC hubs report activities and interventions to the Ministry of Health on a monthly and seasonal schedule. Being housed within the health unit, the hub is also required to capture interventions under Ontario's public health standards. The hub maintains a system of communication with partner facilities as a means of engagement. The hub performs continuous quality improvement to ensure ongoing work is of benefit and meets needs as they arise. As with any healthcare program, resources such as time, funds, and staff energy need to capture value as a return on investment. The health promotion documentation system was developed internally at the health unit to function in place of an electronic medical record where no personal health information is captured, while collecting data points related to Ontario public health standards. The hub adopted the use of HPDS in September 2024. Data points were mapped to fields in HPDS, user guides were developed to ensure consistency of documentation, and staff were oriented before go-live date. By September of 2025, a full year's worth of data could be extracted, demonstrating all hub interventions and interactions with partner facilities. To gauge effectiveness of hub interventions, a comparator of outbreak metrics were chosen. Ontario's 2021 Fixing Long-Term Care Act mandates reporting of outbreak information to public health units. This made the 10 long-term care homes served by the hub an immediate first choice for collecting comparative data. Outbreak metrics measured were number and duration of outbreaks and number and symptoms of cases. These metrics provide a brief picture of illness incidence, severity, and spread to demonstrate how facilities were both preventing and controlling infections. Skewed outbreak numbers during the pandemic and the timing of the HPDS data extraction meant limited timeframes were available for measurement. Historical data averaging outbreak metrics from September to December of 2023 and 2024 was used as a precondition, against the same metrics from September to December of 2025 as a postcondition. Data was extracted from Ontario's Integrated Public Health Information System and facility line lists through TVDHU. Data was confirmed as anonymized, and comparative reports of the selected metrics per 100 facility beds were compiled. The full project allowed a cyclical approach to data collection, analysis, evaluation, reporting, and continuous quality improvement. As stated, required data was determined first. Then data was mapped to fields in the HPDS software. Clear workflows were developed and communicated to staff. IPAC Hub activities and interventions were documented into the software as these occurred. Each month, data was extracted, sorted, and analyzed. A quality control check was performed against IPAC Hub calendars to ensure completeness of entries. Feedback went to staff to ensure accuracy of documentation and fed back into the software. Monthly reports to the Ontario Ministry of Health were generated using the extracted data. In September 2025, a full year of data was extracted to analyze and show levels of facility engagement with the hub, as well as types of engagement. The analyzed information was compared against the information about facility outbreaks during the determined time periods. This allowed reports to be generated which showed levels and types of facility engagement with the hub and possible association to outbreak metrics. Finally, the analyzed information provides a basis for ongoing program planning and improved intervention effectiveness. The results of the project are as follows. Professional standards were met. Each staff interaction with facility members was documented and recorded. Provincial reporting was simplified. Monthly reports are now generated from data captured during documentation. Any questions which arise from the reports can be answered by reviewing the documentation. Facility engagement is measured. The hub can track the frequency and type of interaction staff have with each individual facility served. This allows hub team members to objectively review levels and types of engagement. Effectiveness of IPAC hub interventions are evaluated. A preliminary analysis showed distinct outliers, but also a possible association between increased levels of engagement with the hub and decreased levels of outbreak incidence, severity, and spread. This allows evidence-based responses from the hub, provides information to promote facility engagement, and informs planning. Return on investment can be calculated. ROI, defined here as resources spent in IPAC Hub activities versus known cost of outbreaks in additional staff, equipment, and sick time, can now be calculated and expressed to show the value of the IPAC Hub as a program. Documentation using the HPDS software has proved to be effective for data collection through a regular professional expectation while not adding an administrative burden to staff. The apparent association between engagement and outbreak metrics can guide IPAC Hub QI and planning while being communicated to facilities to increase partnerships. The limited study size impacts the power of the study. There appear to be associations, but true correlation or causation has not been proven. Further time using HPDS and broadening the scope of the study will help determine if the apparent association can be statistically proven. In conclusion, who should care about documentation? Everyone. This study has shown how an effective system for documenting IPAC activities has fulfilled professional requirements while also allowing data extraction for multiple purposes. Returning to the map in the forest analogy, we all know the next IPAC crisis is coming, so the higher quality information we have to navigate, the safer everyone will be. For our team, the map to find our route through the forest becomes more complete with every activity of the IPAC Hub and every entry into HPDS. And no IPAC professionals were lost in the woods in the making of this video.